in the field of reproductive medicine. Sir is a reproductive medicine specialist and founder, medical director of Mumbai Fertility Center and IVF Clinic. And he has pioneered several evidence-based, patient-centric ART practices that many of us follow even today in our day-to-day practice. Few things which, I'm very happy to, share and also read about him, which I wanted to share is, Sir has worked with pioneers who had began IVF in India. Sir has worked with Dr. T.C. Anand Kumar, reproductive biologist and embryologist. He successfully established pregnancies in more than 18,000 infertile couples since 1994. He has had many awards, which is a whole list of awards. I'm not able to compile in this thing. He's got many awards, lifetime achievement awards, and he has established many fertility clinics across India, and everybody owes to him for our continued success rates and how we have evolved from last 3 decades. Without much ado, I express my sincere gratitude for him, to accept this invitation to share his expertise in the field of reproductive medicine. And today he's going to talk on ICOS, or Individualized Control Ovarian Stimulation Protocol, which is going to represent the next step in personalizing ART treatment. As we all know, instead of one size fit all, we have to move on to a personalized approach, whether it is a gonadotrophin type or the protocol or the trigger. The goal should be simple in giving us maximizing the oocyte quality, reducing the patient risk or prevention of OHSs, and ultimately give an excellent cumulative live birth rates. So nobody else could make more justice to this topic other than Dr. Jatin Shah, and we welcome you, sir, for this masterclass series, and kindly take over this session, and we are more than honored to hear from you in the next 1 hour. Thank you so much, sir.
Thank you so much, dearest Vasundara. That was such a lovely introduction. I'll just share my slides.
And I wanted to say one more thing. Thank you, everyone. It's because of Jatin Shah sir's lecture today. Our usual timing was 7:30 to 8 p.m., sir, 8:30 p.m., sir. And you said 5 p.m. and there is a whole lot of audience waiting to listen to you. It's your magnetism. Thank you so much, sir.
Thank you. Thank you. So one small diversion here. Of course, I took the liberty to do this because I'm really excited for 2026. We have a lot of new advances, not only in ovarian stimulation. So today's highlight is, of course, going to be not my usual talks, but telling you what's new, how to go about even more individualizing of our practice. And I took the liberty of not only covering ovarian stimulation protocols, but also talking a little bit about how you should be doing embryo transfers in 2026. So a lot of new advances, and let's begin then with this fascinating journey that we have for the next 1 hour. So of course, we can't help mentioning that all of us exist in our careers purely because of an event that happened at the stroke of midnight, 25th July 1978, when we had Louis Brown, the world's first IVF baby, thanks to Robert Edwards, Patrick Steptoe, and Jean Purdy. The reason I'm mentioning this is not that you don't know this, but because you must remember that Louis Brown was born in a natural unstimulated cycle from an oocyte that was retrieved in a natural cycle, and more importantly from an embryo that was a fresh embryo transfer, that too in a natural cycle. So we need to remember that 40, almost half a century down the line, we need to think about going more and more back to nature in our approaches to IVF, and that is what I'm going to tell you today. So of course, we know that to begin your individualization as to how you should go about treating a patient that has walked in, you first need to know that is she going to be a poor responder, a normal responder, or a high responder. And for ages, we have depended on age, BMI, her previous response, whether she has associated PCO and endometriosis, and so on. But the most important, of course, markers for us have always been a combination of AMH and antral follicle count. But remember, there are now some studies to show that either of them alone is not reliable. I'm sure all of you would agree that many a times you have an AMH of 2.5, and then when you look at the ovaries, you just see 2 or 3 antral follicles, and vice versa. And recently at the Paris ESHE conference, there was an update that AMH measurements, which are older than 3 months, are associated with reduced predictive accuracy, and using these older measurements could be associated with a greater over prediction of oocyte yield. To my mind, the most important predictor of how you should select an analog or select a starting dose of FSH or whether to add LH from the beginning should be one and only the most important parameter, especially if she's had a previous IVF cycle, which most of our patients have had usually, is to study in detail her previous response to stimulation. So you must go into every possible detail of whether it was a short or a long protocol. 90% of the time, most clinicians prefer the short antagonist protocol. Was treatment started on day 2 or day 3 or even day 4? Was any kind of pre-treatment used? Was she stimulated with FSH alone or was LH added from the beginning? Or was she switched to HMG on day 7? Did she have a fresh or a frozen transfer? Did she have a day 3 or a day 5 transfer? Was PGT done? So on and so forth. So once you take all this into account with the age, AMH and AFC, you would then be able to come to some kind of conclusion as to what would be the best protocol for this patient to optimize her outcome. So as I told you, the most valid starting dose predictor is response in a previous cycle, as this Delphi consensus from Spain in 2023 showed. But despite our best efforts, I'm sure all of you agree, we still end up and mostly have patients who belong to either Poseidon 1, 2, 3, or 4. So 1 and 2, for those of you who are beginners, to put it simply, are young and old patients. They came to you with a normal ovarian reserve. You gave them a dose which you thought would be adequate, but you ended up with a suboptimal response, either less than 4 oocytes, that is subgroup 1A, or 4 to 9 oocytes, which is subgroup 1B. So young and old Poseidons 1 and 2 are very often iatrogenic and could have been prevented if more attention was paid to each and every detail of her stimulation. And then of course you have the expected group, that is the Poseidon 3 and 4. That is your young and old patients who come to you with a reduced ovarian reserve. You know that she is not going to give you a good cohort of oocytes and embryos, and this is where you again need to pay more attention to get them going. And all of you would agree that the biggest chunk of our patients today is Poseidon 3. These are young patients under the age of 35 who come to you with a low AMH and a low ovarian reserve. So before we jump into management, you need to understand the pathophysiology a little more for these poor responders. So of course, we now know that there are 4 stages of these poor responding patients. Number 1 is a well compensated stage. Number 2 is a stage where she is in a stage of desynchronization of her cycle. Number 3, stage of pathological premature LH surges. And number 4, stage of severely suppressed follicle growth. So what is the compensated stage? She comes to you with a low AMH. She will have a high FSH on day 2. She will have normal E2 on day 2. She will develop a mature follicle which goes beyond 18 to 20 millimeters like a normal responder, and therefore she will have a normal cycle length of more than 26 days. This patient will do well mostly with any protocol that you use and should give you a good response. But remember that in some poor responders, as a woman ages, the cycles become irregular and cycles start collapsing into each other. So here you can see how the luteal phase of this cycle has merged with the follicular phase of the next cycle. And what do we mean by that? That there is a fall in inhibin levels in the luteal phase of these women above the age of 35, as a result of which there is selection of a dominant follicle, which begins to grow even before menstruation occurs, and then it creates havoc in the next cycle, which sometimes would be your stimulation cycle. So this is the commonest stage, that is the stage of desynchronized cycles. Here she comes with a low AMH, of course, normal FSH on day 2. Now, how did the FSH normalize? Because she already developed a dominant follicle, which started secreting estradiol. So estradiol will be high on day 2, and this estradiol negative feedback normalizes the FSH level. So that is the clue to you that she has already selected the dominant follicle. So you should not be starting stimulation on day 2 or day 3 for this patient, or else you will end up with a completely asynchronous cohort. Development, of course, she will develop a mature follicle which goes beyond 18 millimeters. And because her follicular phase, the early part, merged into the previous luteal phase, she will tell you classically that, doctor, last 1 year I have short cycles. I just have a 22 or a 20-day cycle. Third is the stage of pathologic premature LH rise. Here you have low AMH, high FSH on day 2, normal E2 on day 2. They are prone to premature LH rises even if you start the antagonist at 14 millimeters, often resulting in premature rupture of the follicle before you can give the trigger, or even after you have given the trigger, but before you do the egg retrieval, they already rupture their follicles and they have a short cycle length of less than 26 days. Finally, you have the most severe stage of severely suppressed follicle growth, very low AMH, very high FSH, low E2 levels, suppressed follicle growth. They just don't respond whatever protocol you use. They have long, often irregular cycles, often premenopausal or perimenopausal, where you would try your intra-ovarian PRPs and so on, but most of them would finally end up with an egg donation program. So how do you go about treating Poseidon 1 and 2? Means if you know that in a previous cycle she's been a Poseidon 1 and 2, remember that the four possible causes or the commonest causes: one, a low starting dose of FSH. You thought that 225 or 300 would be adequate, but maybe she needed 375 or 450. Number two, she is a carrier of an FSH or an LH receptor polymorphism. Number three, asynchronous follicular development. And number four, your triggering was inadequate. So let's see the starting dose that you should use. Now, if you pick up any human reproduction and read any paper, you would see most of the time European groups tend to give 150 as a starting dose. But remember, Indian ovaries are not as sensitive as white Caucasian ovaries. And studies like this, done by Padma Rekha and Fadi Sharara 2022, clearly show that the Indian predicted normal responder needs a daily starting dose of 225 and not 100 to 150 as we often tend to give. At the same time, very high starting doses of gonadotropins are not associated with increased oocyte retrieval in patients with low and intermediate M2 predictions. So if you know that she has an AMH of 0.5, then if you give her doses of 600 or 1200, it's not really going to work. So you need to be moderate in your selection of the initial FSH dose. What about polymorphisms? Again, Western studies apart, please focus on Indian studies. We have a study here from 2023, clearly identifying the high-risk genotypes which are associated with a poor response to ovarian stimulation. So you can see the various polymorphisms which have been put down here for the AMH receptors, for the FSH receptors, and for the LH receptors that are common in Indian women. Number three, pre-treatment to avoid asynchrony. Now remember, for a short antagonist cycle, you have to give some form of pre-treatment. And we have very commonly several methods of doing this. Number one, somebody's, hello, yeah. Luteal estradiol valerate, of course, is very, very popular. You just have to give her 2 milligrams twice a day, 4 milligrams from day 25. You continue this during her menstruation. The beauty of 4 milligrams a day is that it does not inhibit menstruation. So she will menstruate at her regular time, but the dominant follicle will not be selected because of the estradiol feedback. You continue the estradiol. Maybe she comes to you on Monday, which is day 2. You don't want to begin stimulation. You continue the estradiol valerate till Thursday, then begin FSH or HMG from Friday, at which time you can also discontinue the estradiol valerate. So what have you achieved? You can easily schedule and postpone the retrieval by 4 or 5 days, which is usually the buying time that you need to avoid a weekend. You have also prevented the selection of the dominant follicle, so you get a perfectly synchronous cohort. Another very popular method is to use the antagonist on days 2, 3, and 4. And this is particularly useful if you see a dominant follicle on day 2. So if you see a one follicle on day 2, which is already 12 mm in size, just administer the antagonist on days 2, 3, and 4. Call her in on day 5. You will see that the dominant follicle is no longer visible, and then begin your stimulation. A word of caution here that when you give 3 days of antagonist, there is quite severe suppression, and therefore just giving her FSH alone may not be enough. So you have to remember to add 75 or 150 IU of LH on day 5 along with the FSH to ensure that you don't have a slow response or a kind of a hypo responder. If you have to use an OC pill, then it has to be a low dose OC pill. Begin from day 2. Do not administer for more than 10 to 12 days. Usually stop on a Sunday, give her a 5-day washout period, and begin stimulation from Friday to again ensure that you get a uniform cohort and also to schedule your retrieval for the weekdays. Now, a lot of you would argue that why is he always talking against the OC pill, that too giving it for 15, 20, 30 days, when all the American clinics are doing that? Yes, I agree with you. If you pick up any fertility sterility, it always mentions pre-treatment with a birth control pill, and then they begin stimulation after a 5-day washout period. But remember that any article, just as human reproduction will always start 150 rec FSH, most American clinics, more than 90%, will begin stimulation with a combination of FSH and HP-HMG. And that is the trick, that if you want to use OC-pill for pre-treatment, remember the 5 to 7 day washout period is mandatory, and you have to add LH right from the beginning of stimulation to offset the overly suppressed LH level. So you then give a combination of REC FSH and HP-HMG to these patients. But of course, the best way to achieve synchrony, because here we are not talking just about achieving synchrony. I also told you about pathological premature LH rise. So there comes a big role for the agonist. So tell me which analog wins. Which analog can maintain stable and low LH and progesterone levels throughout stimulation? Which one will give you perfectly synchronized follicles, give you a higher number of oocytes and embryos, will ensure that there is no selection of the dominant follicle in the luteal phase, will also ensure that 100% you will not have any premature LH surges, and will give you a much better endometrial receptivity for a fresh embryo transfer. Again, a lot of you would wonder that why are we talking about fresh transfers in these days of freeze-all, and that is what I'm going to come to later, that we have to abandon this policy of doing freeze-all for all for a lot of our patients. So therefore, the long agonist should be your first choice protocol for all proven poor responders. This is a group which is never going to have hyperstimulation, and it's important that you get each and every oocyte from these patients. So if you have 5 follicles, you want 5 oocytes. If you have 3 follicles, you want 3 oocytes, and not just 3 oocytes, you want 3 metaphase 2 oocytes. So what is the evidence to support? Here you can see agonist versus antagonist in fresh IVF cycles, Zoo in 2019. Clinical pregnancy rate 32% with the antagonist, 58% with the agonist, and enough number of patients, more than 600 almost in each arm. And you can see statistically significant difference in most of the outcomes when you use the agonist as against the antagonist. Even more important was Huang's paper in 2018, who clearly showed that for our majority group, the Poseidon 3, you can clearly see with the agonist, live birth rate of 30.8% versus 16.7% with the antagonist. So there are almost 30 to 40 papers now clearly rejuvenating the use of the agonist for poor responders and even for some of your normal responders to prevent them from becoming a Poseidon 1 or 2. So why are pregnancy rates lower with the antagonist, especially in fresh embryo transfer cycles? The main point here is that with the agonist, you have much better endometrial receptivity. You have significantly lower hoxatin expression in the endometrial stromal cells in an antagonist protocol as compared to the agonist. And often with the antagonist, you have a thinner endometrium with impaired receptivity, giving you lower implantation rates with good quality embryos. What is the importance of the trigger? Of course, for a normal responder, it doesn't really matter. But for a poor responder, as I told earlier, you want almost a 90 to 100% conversion to metaphase 2 oocytes so that you get a good proportion of top quality embryos. And here, the dual trigger is what is recommended. You can see here a study comparing HCG alone versus a combination of HCG and the agonist, and clearly live birth rates almost double from 14.5 to 27%. The whole logic is that when you look at a normal menstrual cycle, at the mid-cycle peak, when you have a LH peak, you also have a FSH surge. Now, when you give HCG, you are only simulating the LH peak and you are not giving her any FSH surge at all. So when you use a dual trigger, you are sure that you are also giving her an FSH surge, and it is this combination of FSH and LH surging that will give you maximal conversion, meiotic maturation to metaphase 2 oocytes. Another very important paper, 2025, that what should be the duration between the pickup and your agonist or HCG trigger. So remember, when you are doing egg freezing for a young girl, you will always give an agonist trigger. It's better to do pickup at 36 and a half or even 37 hours to get a higher number of M2s, because in this category of patient, number of M2s is what matters the most to the young girl. HCG trigger, you will have a higher number of metaphase 2 oocytes when the interval is around 36 to 36 and a half hours. So this benefit is especially seen in older age groups for various reasons, and this is the type of individualizing you need even for your pickup timing in different categories of patients. Moving on to Poseidon 3 and 4, of course, these are the expected poor responders. You know they will not respond well. Adjuvants, we know we are flooded in the market with all kinds of adjuvants, but which are the evidence-based supplements that we have today? Number one, androgens, including DHEA and testosterone. Number two, coenzyme Q. And number three, growth hormone. So these three, as per this large meta-analysis, are the main supplements that really seem to be of help and really seem to improve outcomes. Of course, you know, it's very difficult to do any kind of double-blinded RCT for adjuvants and supplements because there are too many variables which are involved in IVF success. So finally, it comes down to your experience and whatever supporting data that we can get from the literature. So we all know that with advancing age, there will be a drop in total testosterone, DHEAS, free testosterone, and androstenedione. And we also know that when you give androgens, you will increase, as you increase the amount of androgen which is given exogenously, there will be an increase in the number of FSH receptors, thereby making the ovarian response much better to exogenous FSH and HMG. LH supplementation, very important. For far too many years, we have gone back and forth on the need for LH for different groups of patients. But we now generally agree, and there is enough evidence to support that all women above the age of 35 should receive LH not from day 7, but right from the beginning of stimulation. All your hypo responders, who are the likely carriers of polymorphisms, who respond very slowly and have long follicular phases, again, you must try to give it from day 1 in her second cycle, even if you added it on day 6 or 7 in a previous cycle. All patients with hypogonadotropic hypogonadism, remember the starting dose for these patients is usually 300 of FSH and 300 of LH. Anything less than that, they are unlikely to be responding. So don't give 150 or 225 to a hypo patient. The response usually begins only with doses of 300 IU, and that too HMG, that is FSH and LH from the beginning. All your Poseidon groups will need LH supplementation. And now we have the Megaset HR trial also supporting the use of LH from the beginning in your high responder and PCO patients as well. In India, we have a tendency of beginning with FSH, and then on day 7, for some reason, we switch to HMG. Please remember that this is not going to improve your pregnancy rates. You can see this study here from Berker in 2021 for Poseidon 3 and 4. Early follicular HMG means beginning HMG or adding LH from day 2 will give you a higher live birth rate at 22% as against just adding LH or switching to HMG from day 7 or day 8. So please keep this in mind and try to give LH right from the beginning. If you think she's a potential normal responder, maybe you will give 225 of FSH and 75 of HMG or LH. And if she's a poor responder, she probably needs 150 of HMG or LH right from the beginning of stimulation. What about the new PPOS for poor responders? We are all familiar with the use of PPOS for high responders, for our PCO patients, for our egg donors. But what about poor responder groups where you are planning a freeze-all? The main point here to remember is there a difference in euploidy rates? Now remember, your Poseidon 4, women above the age of 35, the oocytes may not take too well to synthetic progesterones being given during the follicular phase. So Polysaucin 24 compared PPOS versus the antagonist and the embryo euploidy rates in across all spectrums of patients and found that there was no compromise in embryo ploidy rates. But recently, Chang in 23 showed that especially in women above the age of 37 or 38, you can see with antagonist, euploidy rate was 26.7%. With PPOS, it was just 5.4%. So just a word of caution that don't use PPOS for all your patients. Be a little careful with women above the age of 38, because probably periovulatory exposure to high doses of synthetic progesterone in this group could reduce the number of antral follicles, the oocyte health, the meiotic conversion, and the cytoplasmic maturation for these patients. But of course, that's not, after that, we still have one more study which again has shown that there is no difference in euploidy rates. So we have a bit of a controversy here, but there's nothing really to think too much about. You can easily use the antagonist protocol for women above 37 until we have further clarity on the PPOS use. What about dual stimulation? And this became really popular during the times of COVID when Ubaldi first presented that you should do exploit 2 or 3 menstrual follicular recruitment waves during a single menstrual cycle. And we had papers showing us, for example, here that follicular phase generated embryos versus luteal phase generated embryos. There was almost a doubling of the pregnancy rate, showing that luteal phase generated embryos are better. And we also had studies showing that they had the same clinical obstetric and perinatal outcomes. So it was better to do back-to-back stimulations, follicular followed by luteal, within one menstrual cycle to get the maximum number of oocytes for these patients. But suddenly there seems to be a twist in the tail, and we now have to look back again at basic physiology that when we do dual stimulation, we always give an agonist trigger in the follicular phase. And when you do this with the agonist trigger, we know that the luteal phase is very short. We know that there is premature luteolysis, and even most of the time the patient menstruates within 3 or 4 days of the egg retrieval when you've given an agonist trigger. So how then can you call it a luteal phase stimulation? And very simply, all you needed to do was just check the estradiol progesterone levels on day 2 of the so-called luteal phase, and you will find that these levels are exactly the same as day 2 of a follicular phase, and you don't have elevated progesterone levels when you have given an agonist trigger. So what we were doing was in fact just back-to-back 2 consecutive follicular phase stimulations. Also, because of the back-to-back stimulation, you could not do fresh embryo transfers. And at that time, there was not much data, but now we know that macrosomia is a real and present danger with doing too much of freeze-all and FET cycles. So the correct way of doing a dual stimulation would be that the first stimulation should be in the true luteal phase. So you document ovulation, you then begin your FSH or HMG, add the antagonist, give an agonist trigger, do your first retrieval, wait for menses, now do your classical follicular phase stimulation. This time give an HCG trigger so that you have a good endometrium, and then transfer whichever embryos were of better quality so that you have a functioning corpus luteum in early pregnancy. You avoid the risk of PIH and macrosomia, and you also given the patient a chance to pool more oocytes and more embryos by doing a true dual stimulation. So this was pointed out by Raka, that what we have been doing all this time has been wrong and not very truthful about the fact that it is a luteal phase stimulation. A few things about the poor responders before we move on is the laboratory aspects, because often there is a misconception that you must do ICSI if you have only 2 sites, or you must do PGT because poor responders have higher risk of anomalies and miscarriages, and whether you should be doing oocyte activation for all these patients. Number one, please remember that ICSI, there is no evidence anywhere in literature that ICSI is better for poor responders just because you have fewer oocytes, or that it is better for women above the age of 35. So please go by your regular laboratory criteria. Don't do ICSI for all your patients, because we have some evidence now in June 2023 when Valerie Baker presented her study following up 200,000 infants born through IVF and ICSI, and showed that when you do ICSI in the absence of a male factor, you are increasing the risk of birth defects by almost 30%. So please be very careful. One intervention that you should do, and which is really easy for all your Poseidon 4 patients, that is women above the age of 35 with a poor ovarian reserve, once you have injected the oocyte, just put it into a calcium ionophore activation medium for about 15 minutes. Then wash it off with HIPIS buffered medium, transfer it to your regular bicarb buffered medium for further culture, and you're likely to have a much better outcome in terms of quality of the blastocyst and in the overall blastulation rate, giving you 1 or 2 more embryos for a good embryo transfer. PGT, remember that many a times you have convinced a patient, say, who is 37-year-old with a low AMH, oh, you must do genetic testing. You prove to her that you have a euploid embryo, a euploid blastocyst. You transfer the euploid blastocyst, she gets pregnant, and she again has a early miscarriage. So remember, everything about an oocyte is not just the genetic spindle, and you have to pay a lot of attention to aging, to mitochondria, to the cytoplasm, and all the other components of the oocyte and embryo before you recommend PGT to these patients. And to address this issue, we finally have a wonderful paper in the form of Opening the Black Box of PGT, that why do euploid blastocysts fail to implant, by Laura Renzi, Carlo Alvigi, and Ubaldi in 2023. They analyzed more than 400 papers, which were genuine academic papers on PGT applications, taking into consideration 1,600 items and all kinds of parameters: embryonic, maternal, paternal, clinical, and laboratory, and finally concluded that just because we have done a euploid blastocyst transfer, you cannot compensate for advanced maternal age. The pregnancy rate will not improve. You will probably just eliminate a few early miscarriages. You cannot compensate or help a patient with recurrent implantation failures, and you cannot help a patient who primarily has a embryo which is not of a very good grade morphologically by visual inspection. So please be careful, because there's too much of misapplication of PGT happening, and we find that success rates have dropped with this injudicious use of PGT for all our Poseidons 3 and 4, informing them that you have a higher risk of miscarriage and so on, which in fact is not true. So Poseidon 3, we know that the pregnancy rate per transfer is the same as a normal responder. So please use this point in your counseling. They have only a lower cumulative live birth rate. And why is that so? Because they give fewer oocytes. So you have fewer embryos for multiple FET cycles, which is why your cumulative live birth rate may be lower, but your pregnancy rate per transfer is going to be the same 40% as you would get in a normal responder. Now coming to what is new, and that is the two main points for today. One is the whole concept of early triggering, especially in women of advanced age, above the age of 35. And the other is delayed triggering for women who just don't give you even one normal embryo. So these are two different categories: early triggering for women of advanced age, delayed triggering for any patient, young or old, not necessarily a poor responder, may even be a normal responder. You can delay the triggering to improve egg quality in some of these patients. So the whole idea of this delayed triggering or term stimulation was that you extend the follicular phase to the full 17 days. And the 17 days we know is what you have in a normal menstrual physiological cycle, which we have been truncating to 10, 12, 13 days by triggering early. The whole idea of term stimulation is to maintain FSH levels in a narrow individualized range to promote term born competent eggs. And we know that this is particularly important, and also tells us that don't overdose with FSH in any patient, because it is often detrimental to the final quality of the oocyte. So remember that as of now, this concept is just applicable for patients with at least two previous IVF failures, which failed either due to poor embryo quality morphologically or arrest of embryos, or gross aneuploidies on PGT testing. So here an example case was a 37-year-old patient, AMH 1.8, two previous IVF failures. You can see first cycle, conventional stimulation, 13 days of stimulation. She had day 3, very poor quality embryos. Second cycle, 13 days stimulation, no development of even one good quality embryo. The third was the term stimulation, fixed 17th day triggering, irrespective of follicular sizes. And you will see, in fact, she consumed much lower IU of FSH as compared to the conventional groups, because we had to maintain the serum FSH levels at a particular level. And you can see for the first time she had 5 top quality blastocysts. Of course, the authors have gone on to finish 50 or 60 cases. I think there's going to be a publication soon, and maybe this will be a norm for patients who just don't give you a normal embryo and are not ready for oocyte donation. So how do you do it? Very easy. You can see you have to use the long agonist protocol, because you don't want premature LH surge, because you're going to be triggering very late. Basal FSH for this patient was 2.8. So your target serum FSH is just about double, which means 5.6, which puts the range between 5 and 10. You can see they started with 300, quickly dropped to 150 because the serum levels were exceeding 10, and they maintained 150. And you can see serum FSH maintained between 5 and 10. Then they even dropped stimulation for a day. So coasting on one day here, coasting on one day here. As long as serum FSH remains between 5 and 10, triggering is done on day 17. You can see follicles as expected will be very large, 26 mm, 23 mm, and so on. And that is when they found that they got 5 top quality blastocysts. So this might help some patients where the oocytes and the follicles require a longer duration of development to give you the best top quality embryo. What about early triggering for some women of advanced maternal age? And we know with advanced age, there could be a lot of ovarian fibrosis, and often follicles are not able to grow beyond a certain point. So Barad and Gleicher were the first to show that as age advances, maybe triggering should be done at smaller sizes. So you can see here triggering even at 14 mm, even at 12 mm if it's a 45-year-old patient. Of course, we don't do too many of these, but even at 40, they advocate that you can give it at 18, and beyond 40, you can give it at earlier follicular sizes. But Wu later on showed, that was the next paper that came in for women between 41 to 43. He compared two groups, triggering at 16 mm versus triggering at 19 to 21. And the early 16 mm group had less atretic, more immature oocytes as expected, but more top quality embryos, and also which equated into a higher clinical pregnancy rate. But the most important evidence, most of you would think that's just one paper, how can it be the gospel truth? But the most important paper is by Lawrence in 2024 in USOG journal, which has an impact rating of which is higher than fertility, sterility, and human reproduction. So you have to take the paper very, very seriously. Do women with severely diminished ovarian reserve undergoing modified natural cycle IVF benefit from an earlier trigger at a smaller follicular size? So we have to remember that many of these patients have short menstrual cycles due to a shorter follicular phase, as I showed you earlier when we were discussing pathophysiology. And what really happens, you can see here follicle size even 12 mm, 13 mm, 14 mm at the time of trigger. 100% of these patients had oocytes retrieved at egg retrieval. What about M2s will be your next question. You can see even when you trigger at say 11 mm size, 60% of the oocytes will be M2s. At 14 mm, you will see here almost 80%, and at 15 mm, 90% of your oocytes are likely to be M2s. So this is a revolutionary new concept, because we always think that if you trigger anything before 18 mm, you will not get mature oocytes. What about their laboratory outcomes after fertilization? And you would be surprised or rather shocked to know that when you trigger at 10 to 13 mm for these women of advanced age, you get the highest fertilization rate at 81% and a very high blastulation rate at 61.5 as compared to triggering at larger follicular sizes. So this is truly a great breakthrough that we have had with this paper, and how we should individualize and trigger early for a lot of these women who are above the age of 40. So the paper observed that the likelihood of retrieving a M2 oocyte seems similar for follicles which are larger or even smaller than 15 mm. Optimal maturity rates were observed for follicles between 13 to 17, and live births have resulted from oocytes retrieved from follicles as small as 12 millimeters. So this is really eye-opening for us. Asia 2025, again, two things I was very happy about, which was the consensus was reached that letrozole and clomiphene add-ons are not routinely recommended for any type of responder. Most importantly, hormonal monitoring during stimulation is not routinely needed. So any of you who have been following me for the past decade or so would always remember that I never do any hormonal monitoring during a IVF cycle. So for me, it's always been AMH before starting and HCG to confirm whether she conceived or not. And we never do E2 levels, LH levels, and so on. The only place where I do one progesterone estimation on the day of HCG is if I am contemplating a fresh embryo transfer for that patient. So finally, we have agreement from ESHRE, what I have been saying for the past 2 decades, that you do not need to keep monitoring hormone levels if you are doing a good transvaginal ultrasound for monitoring the cycles. So to end with the poor responders, of course, this was the paper 2025 because there's so much confusion about what works and what doesn't work. DHEA significantly increases the number of oocytes retrieved, although critical pregnancy rate was not really affected. And there is a paper just last week in Fertility, one of the largest RCTs on DHEA, again showing that DHEA is not of much use. Testosterone, on the other hand, significantly increases not only number of oocytes but also improves clinical pregnancy rate and live birth rate. Low dose natural cycle IVF and so on is not recommended. You must do a conventional, normal, or high dose gonadotropin treatment for all poor responders and try to avoid minimal or mild stimulation protocols because you won't get enough oocytes and embryos for giving her a cumulative live birth rate. And that brings us to what I do in day to day practice. Of course, for Poseidon's 3 and 4, there is 60 days of pre treatment. Coenzyme Q with resveratrol, leucine, glutathione, vitamin D, and folic acid. We've also added melatonin to this list. Testosterone gel twice a day for 20 days pre-stimulation. First choice protocol long agonist starting with HMG and not pure FSH alone. Second cycle short antagonist with some form of pre-treatment which is mandatory, again using a combination of FSH and LH. Dual stimulation as of now abandoned until we get the results of the new study by Annalisa Raka. Fresh embryo transfer, more and more of these we are doing now. If progesterone is between zero point 0.5 and 1.5 on the day of HCG and you have one or two top quality embryos, you can go ahead with fresh embryo transfer as well. What's new with the PCO group? And here, of course, we need to remember that now there are studies showing that chronic low-grade inflammation and ovarian dysfunction is seen not only in the aging woman, but also in patients of endometriosis and PCOS. And we know from this paper in 2023 that hyperandrogenism, insulin resistance all contribute to chronic low-grade inflammation. Pro-inflammatory cytokines and so on increase the oxidative stress, increase fibrosis in the ovaries, and therefore this impairs follicular development, giving you poor oocyte and embryo quality. So of course, the future is going to be that we have to tackle this chronic low-grade inflammation and fibrosis in our PCOS patients, taking into consideration not only antioxidants and insulin sensitizing drugs, but also anti-aging drugs, immune checkpoint inhibitors, and anti-fibrosis drugs. So, of course, this is all coming up. And for some of you, this might come as a shocker because we would never have imagined that a PCO patient would ever need androgen supplementation. We always feel that we don't have to give them any androgens. But here we have a new study now that especially the thin lean PCO patients, that is your classic phenotype D, proven now that they are hyperandrogenic until the age of 25. They become normal androgenic between 25 and 35, and they become hypoandrogenic after the age of 35. So maybe there is a case for DHEA or testosterone supplementation for your thin lean PCOS who are above the age of 35. So you can see this rapid decline in androgen levels, which is seen in the thin lean PCOS phenotype D of PCOS patients, which needs to be taken into account. Also, those of you who are at Paris Echre would recount this paper. Lot of attention now being paid to microbiome and the gut microbiome, not only for other factors, but even for PCOS. They have clearly proven a significant depletion of parabacteroides murdae in PCOS patients. These may then serve as emerging biomarkers for reproductive risk, and targeted probiotics, dietary BCCA modulation all need to be considered when you are managing a PCOS patient. What about the new GLP receptor agonists, all your Munjaros and Ozempics for PCO patients? We know that they are the group who are most likely to benefit because it's well documented that they have a great effect for weight loss, tackling insulin resistance, particularly beneficial for most of our PCOS patients. Short-term use in obese women, even if you give it for 3 months and they lose 10 to 12 kilos, you will have a much better outcome in terms of the response to FSH and HMG. And the initial observational studies show that inadvertent early pregnancy exposure to GLP-1 does not necessarily result in adverse neonatal outcomes. And we have another study from Salamoon here that liraglutide in combination with metformin led to a higher cumulative pregnancy rate over 12 months in women with PCOS undergoing IVF. So, of course, with any new drug, we need to be more and more careful for short and long-term neonatal and infant studies. But as of now, we have these 2 or 3 papers that seem to show that there are no adverse effects, even if a patient conceives while on a GLP-1 receptor agonist. What about OC pill pre-treatment for PCOS patients? Again, we have this mental perception that a lot of PCOS have high LH on day 2, which is detrimental for oocyte and embryo quality. Wonderful study here from 2024 comparing the two groups. One where OC pill was given to suppress the elevated LH levels, and the other where FSH was started irrespective of how high LH level was on day 2. They gave a 7-day washout period in the OC pill group. And as you must have already guessed, high LH levels on day 2 did not have any obvious negative impact on embryo quality. So please avoid giving them OC pills for prolonged durations just to reduce their LH levels. Totally unnecessary and does not have any impact on improving the outcomes. Of course, we all know that PCOS very easy to manage, antagonist cycle, agonist trigger, and freeze all for all. So we completely eliminate OHSS. But again, a word of caution that when you give OC pill pretreatment to a PCO patient, you will have excessive suppression of endogenous FSH LH. So then when you use the agonist trigger, you will not have an optimal response. So you can see here, if your LH is overly suppressed because of extended OC pill suppression, you will have almost 40 to 50% of cycles giving you a suboptimal response. What do you mean by suboptimal? Means you see 30 follicles, but you get only 10 oocytes, you get 20 oocytes, but you get just 4 M2s, and so on. This is because the agonist trigger was ineffective in these patients. Agonist trigger and empty follicle syndrome. Many a times I get a call that I used the agonist trigger and I did not get any oocytes. Where does this particularly happen? So you have to be aware that agonist trigger related empty follicle syndrome might be seen in some patients of hypogonadotropic hypogonadism, or almost all cases of hypogonadotropic hypogonadism, because they don't have any endogenous FSH LH to release. So for hypo, as I told you earlier, 300 IU of HMG from the beginning. No need to add the antagonist because they will never have premature LH surges. You cannot use the agonist trigger. You have to use the full-blown HCG trigger for this group of patients to avoid empty follicles. Prolonged stimulation, 20-25 days, use of more than 4,000 IU gonadotropins, recent OC pill use, which I already told you. These are all common reasons for getting empty follicles. Sometimes very early triggering or very late triggering also could cause this problem. PCO, we talk of asynchrony in poor responders, but remember, you often see asynchrony even in PCO patients. And this especially happens if you start with a very high dose. So suppose you give 300 or 375 to a PCO, you will see 3 or 4 follicles racing ahead to 18 or 19 and the others lagging behind at 13, 14, 15. So we now need to have this AI-based algorithm to individualize our dosing for each and every PCO patient. So you can see how it's calculated here. Patient with a BMI of 28, basal FSH 6, LH 8, AMH 8, and AFC 24. The algorithm gives a starting dose of 125. Most of us would have probably given 150 or even 225 or even 300 to this patient, and that is why you would end up with asynchronous follicular growth. So you can see here, when you use the algorithm, as another study showed, you can reduce the percentage of early follicular asynchrony from 17% to 4% and late follicular asynchrony from 37% to just about 2.3%. So individualized algorithm based dosing will be the future in 2026, as against your standard selection of a dose based on your own personal clinical experience. What about PPOS for high responders? Of course, Chen study in 2022 showed that it is not just reducing the number of injections and improving patient compliance, but in fact, PPOS generated embryos gave you a higher clinical pregnancy rate of 61% as against 47% with the short antagonist protocol. What to use? You can use MPA 10, you can use MPA 2.5, you can use just dydrogesterone 20, you can use maybe 100 or 200 of micronized vaginal progesterone, or even just one single tablet of MVP 200 milligram orally usually suffices to completely eliminate the premature LH surge. So nothing much to select, and you really have a big choice of what you can use for PCOS. But despite all this, we still see an increased miscarriage rate. We have tried our myoinositols, metformins, coenzyme Qs, HPHMGs, probiotics, and everything for PCO patients, but yet we somehow get a higher early pregnancy loss rate. So to address this, we have Itakura's new approach for treating some PCO patients, a very novel and different method where again they show that delayed triggering could be the answer to achieving more competent oocytes in high responder patients. So very easy to do. FSH 150 from day 2 was their pilot protocol. They switched to HMG 150 from day 7. Antagonist is added not at 14 mm but when the lead follicle reaches 18 mm. Agonist trigger not at 17-18 but when the largest follicle was 24 mm. One tablet of letrozole if a E2 level on the day of trigger is 4 to 5,000 and two tablets if E2 was more than 5,000. And to compare the outcomes, he compared four groups. One was conventional long protocol, antagonist with HCG trigger, antagonist with agonist trigger, and this new protocol which he proposes. And you can see for the first time we have a drastic reduction in miscarriage rates from 24, 29, and 30 to 19.4%, thereby giving you higher live birth rate from 18, 27, 25 to 36%, and higher cumulative live birth rate from 30, 38, 37 to a wonderful 57%. So again, very important, strong case for a delayed trigger in some PCO women who have unexplained recurrent miscarriages despite your PGT showing that she had a euploid blastocyst. So ASHRAE guidelines for high responders, of course, OC pill is not recommended for all the reasons that I told you, that the agonist trigger will not work effectively. Antagonist, of course, mandatory. You cannot use long agonist for high responders. As I already told you, addition of clomiphene letrozole not recommended. REC, FSH and HMG are equally recommended. Mid stimulation adjustments of doses don't work. Routine use of adjuvant metformin is not recommended and is sometimes detrimental, so don't give empirical metformin to every PCO patient. Addition of estradiol measurements is not recommended. Agonist trigger, freeze-all, and if you have given an agonist trigger, please don't give her any cabergoline, albumin, or anything else. They don't need these measures, and these measures don't work when you have used an agonist trigger. Even if you aspirate 100 oocytes, she is going to be back to normal the next day. At the most, you can give letrozole just to rapidly reduce the estradiol levels if you're a bit concerned, but there is no need to give her albumin or keep her admitted or any other kind of measure. And finally, of course, because I just couldn't help myself, but I have to share some new protocols for embryo transfer, which you really need to be aware. First is, of course, don't do freeze-all for all, and we have clear-cut indications for freeze-all. High responders, we know high or low progesterone on day of HCG. If you've done dual stimulation or random start stimulation, if you have a thin endometrium where you need 25-30 days to work on the cavity and the endometrium, PGT patients, of course, and some patients of endometriosis and adenomyosis will do better with frozen embryo transfers as against fresh. So what's new for endometriosis? If you are planning a ovarian stimulation cycle for an endometriosis patient, this study compared giving her Dynogest for 3 months versus striptorelin, what we've been using agonist for 3 months, versus just directly beginning stimulation with no prior treatment. And the live birth rate was notably lower in the Dynogest group. So please be careful if a patient is on Dynogest. Maybe you should give her a month or two of Dynogest free menstrual cycles before you begin stimulation to avoid this adverse outcome. What about before frozen embryo transfer? Should you be giving the depot for 2 months, or can you use elagolix 200 milligram orally twice a day for 2 months? And they found that both were equivalent. There was no difference between the pregnancy rates. So oral antagonist could be a more tolerable substitute for agonist depot with all its associated menopausal symptoms and side effects in patients of endometriosis undergoing frozen embryo transfer. What about adenomyosis? And here we have had very commonly practice of giving them 2 to 3 months of the depot preparation in an attempt to reduce the size of the adenomyosis, thinking that it will improve outcomes. So Polizos in 2023 did a study comparing two groups, one where 2 months of depot preparation was given versus the other group where no such depot preparations were given. And clearly you can see no difference in outcomes. So please do not give 2 or 3 months of depot suppression with all its side effects to adenomyosis patients, even if you see a significant shrinkage of the uterus, you would all agree that the minute you begin estradiol valerate for these patients, within 10 days, the adenomyosis is back to its original size. So either it needs a good debulking surgery or you proceed with a transfer without any kind of pretreatment is the important message for adenomyosis patients. And finally, why not freeze all for all? And we first got a presentation in 2018 by Rob Norman and Wong, where they compared freeze all versus fresh in non-PCOS patients. And you can clearly see absolutely no difference in any of the outcomes. And yet for the next 7 years, a lot of us went on doing freeze all for all. Is there an advantage of doing fresh followed by frozen as we used to do before the times of vitrification? And this study by Wong in 2020 is, 21 is what prompted me to start doing more and more fresh transfers. So he compared two arms. In first arm, first was a fresh transfer followed by a FET transfer in case the fresh failed. The second arm was FET followed by FET as most of us do today. And you can see the blue line, the cumulative live birth rate of fresh followed by frozen is much higher than doing FET followed by FET. So there are a lot of embryos which prefer a fresh endometrium with nice corpora lutea, giving a lot of growth factors and hormonal support rather than just giving them MVP support, which may not be adequate for a lot of these embryos. And more recently, we have strong evidence now from 2025 RCT of 800 women, live birth rate 40% with fresh transfers versus 32% with FET, clearly showing a tendency to better live birth rates with fresh transfers. In poor responders, what about women of advanced maternal age? Again, you can see 24% with fresh versus just about 20% with FET. So although it may be not statistically significantly different, you can clearly see a tendency to better pregnancy and live birth rates with fresh transfers, especially in your Poseidon groups and Poseidon 4. Coming to preparation, we are all very familiar with our HRT preparations. Many a times, physiologically, you see that when she came to you first, her endometrium was 9 mm or 10 mm. Even during stimulation, she was 9 or 10 mm. But when you give her an HRT preparation with exogenous estradiol, she just doesn't budge above 7 or 8 mm. So remember, there are 10 to 20% of women who don't do well with orally administered exogenous estradiol, and this is the group where you should use vaginal estradiol hemihydrate, and we are about to publish this paper. Just 2 to 3 days is all that you need. The booster dose, 2 milligrams BID or TID vaginally in addition to your oral administration, and you will see an increase of thickness of 2 to 3 mm within 2 days in 70 to 80% of these patients, where the thin endometrium is more functional rather than because of any structural damage or Asherman's, where obviously this is not going to work. The most important point, is it time to go back to nature and to practice embryo transfer just as Louis Brown was born? So remember, initially, most of the studies comparing HRT FET with natural cycle FET showed that pregnancy rates were similar. No attention was given to obstetric and perinatal outcomes. But we now know that the absence of a corpus luteum in early pregnancy, which is meant always the case in HRT cycles, will increase the risk of PIH. You have a doubling of the risk of PIH and a significant increase in the risk of macrosomia as well. And as I told you earlier, 10 to 20% of patients do not respond well to exogenous oral estradiol. So that brings us to natural cycle. And a lot of you will say, but oh, it's so difficult. How can you work 365 days? You can't do any scheduling. You can't change the date of transfer and so on. So today's highlight is going to be what are the various ways in which you can modify your natural cycle to even get the benefits of scheduling and giving the patient the benefit of a corpus luteum in early pregnancy. So of course, we know we are all experts at TVS follicular studies. You don't need LH monitorings or any other hormonal monitoring. You just keep a track of the follicle once it reaches 17 or 18 millimeters. And once you document the ovulation day, it will usually be plus 5 days for a blastocyst transfer. If you have triggered with HCG as a modified natural cycle, it will be HCG plus 7 days for a blastocyst transfer. So till here, all of you know this part. And with this, of course, you immediately reduce the risk of a lot of obstetric and perinatal complications, which were seen with HRT, FET cycles. And that brings us to various modified versions of natural frozen embryo transfers, which will not impact your live birth rate. So, this was the first study which compared a true natural cycle with a natural cycle where MVP was given after ovulation, and the third group was where HCG trigger with MVP was given, that is the modified natural cycle, which is the commonest way most of us used to do it. And the fourth for the PCO patients, where they gave letrozole and HCG trigger, maybe a couple of days of HMG if required, and then MVP. And they found that the live birth rate was similar in all the four groups. So it definitely is as successful as HRT FET cycles. But what about scheduling? Now, suppose you want to avoid a Sunday. The minute you see a follicle of 14 or 15 mm, you just have to give her 2 days of FSH or HMG with an antagonist so that you can prepone ovulation by a day or two. So this is all and as simple as it is, that if you feel that she is going to ovulate in such a way that the transfer would be on a Sunday, you avoid. You just have to give her 2 days of HMG with an antagonist so that you can schedule and prepone her ovulation. So this is one method. The second is you don't even have to wait for 18 millimeters. You can see this paper from 2025 comparing HCG trigger before 16 mm versus a group above 16 mm. And again, they found no difference in clinical pregnancy rates. Of course, I already told you about PCO patients where you give letrozole, HMG, and cetrotide, and you schedule here again HCG plus 7 day for blastocyst, and you will see ovarian stimulation cycle 73% versus HRT cycle just 65%. And this was presented by Roque at 2025. You can see here a novel protocol for FET using letrozole, as I already told you, 5 milligrams days 3 to 7, vaginal estradiol added from day 8, HCG trigger when the follicles are more than 13 mm and endometrium is more than 7. So look at the triggering, anything more than 13 mm, you can give an HCG trigger and significantly improve the live birth rate. So one more new protocol for doing modified natural cycle. And the most significant one was this by Santos Ribeiro in 2024, that you don't even need to wait for ovulation. So you just track the endometrium. Follicle may be of any size, and as soon as you have an endometrial thickness of more than 7 mm, you just begin your MVP and you schedule your transfer. So this is the most important breakthrough that we have now, called natural proliferative phase FET. And you can see with that clinical pregnancy rate up to 57% as against artificial cycles 50%. And most importantly, live birth rate is up from 38 to 49%. And a lot of you would wonder that how would you then have a functioning corpus luteum? First trimester bleeding down from 37.6 to just 17%. So all you need is just to have an endometrium of more than 7. You begin your progesterone irrespective of follicular size, no HCG trigger, nothing to be done. And the logic is that the corpus luteum will be induced the minute you begin a high dose of exogenous progesterone. And this is again a new breakthrough in basic physiology, and that you don't need to even trigger the follicle or cause rupture. You will get luteinization and you will get enough secretion of progesterone from this induced corpus luteum. So with this, again, you can schedule and avoid a weekend. You just have to start your MVP in such a way that your blastocyst transfer falls on a Friday or a Saturday and not on a Sunday. So, of course, the natural proliferative phase combines the benefits of a natural endometrium with the convenience of being able to schedule as you have in your HRT cycles. But I leave you with this paper, which I'm sure will make all of you change from tomorrow to doing natural cycle transfers for all your patients. 5-year retrospective analysis by Molinaro, Fertility, very recent publication, 2025. Most important point, 32% increase in live birth rate with modified natural cycles as compared to HRT FET. So when we keep having these panel discussions on RIF, conference after conference after conference, let's remember that maybe we have always missed this point, that a natural cycle endometrium, a natural corpus luteum would probably be the answer to a lot of RIF patients. So thank you, Dr. Vasundara. Thank you, Dr. Sindhuja. And it's really been a pleasure today. And I hope that I've been able to highlight some of the key points that will help you change your or increase your success rates from 40 to maybe 44, 45, or even 50% in 2026. Thank you so much.
Thank you, sir. I'm just standing to give you a standing ovation from all of us virtually. It's really so inspiring that how you can continue to talk science for 1 hour and 15 minutes. It's like
Oh
you
my
didn't
God.
take a break, and your voice didn't waver. That tells us like how committed in your teaching and your this thing. We thoroughly enjoyed the whole thing. Probably we have to listen to this over and over again for us to keep it in our memory. Yes, there are a lot of questions, but then I would request you to at least sip of water because.
No, no, I'm okay. No, problem. Don't worry.
So, can I take some questions from the chat box, sir?
Yes, please.
Yeah. So, the question is your expected rate of follicular growth and stimulation on day 6, and when will you increase the dosage of gonadotropins?
Day 6 of gonadotropin.
Stimulation, yes.
No, so
So,
normally we
suppose,
expect 13 14 follicles by day 6. If it's not there, then I would step up the LH, not really just step up FSH. So if she was on say 225, I would make it 300 and add LH in some form, or give her a combination of Rec FSH and HMG.
okay, sir. Is there any role where you have added HCG in your stimulation protocol where you have anticipated a poor response during the stimulation?
Yeah, so basically we use HPHMG, which has HCG driven LH activity. It's difficult to give HCG because you don't get ampules of 100 IU and 150 IU and all that. You minimum strength you get is 2000. It's very difficult to titrate. So best is to use HPHMG. We have 2 or 3 brands in the country now where we have HCG driven LH activity available to us. And that's very, very effective and very useful if you add it from the beginning of stimulation.
And it is very important to choose the brand of
Yes, you
HPHMG.
have to ask the company that is this native LH or is it HCG driven?
Yes, sir. And in your practice and experience, what is the maximum dose of gonadotropins that, impacts oocyte quality? So you've never gone beyond this dosage?
450 is my upper cap most of the time.
Okay. And the trigger dose you base on the patient's BMI, sir?
Normally, we give a double of REC HCG for high BMI. So for high BMI, it is 2 of the REC HCG preparations. So that will be almost 13,000 per for the dose. And for normal BMI, we just give 250 microgram of REC HCG. So.
Yes. So many adjuvants are available and so many pharma brands are there. Like, sometimes there's a combination of coenzyme Q, your vitamin D, DHA. Do you
Yeah, so
recommend a,
don't use
do you recommend a
combinations which
combination
give
or embryo?
everything. Don't use combinations which give everything. Select one, just which gives coenzyme Q, maybe a little resveratrol, maybe a little bit of leucine or glycine. That's it. If you have something with 15 things in very small proportions, it's not going to work.
Okay, sir. Any role of short and ultra short protocols, sir, in poor responders?
Not in my experience, I prefer not to use. I prefer the long agonist and it works the best for me.
So with this ICOS you were mentioning, any role of using clomiphene citrate, whether it's in PCOS to reduce their
No,
E2 levels
the
or
X-ray
in
I have
minor
never used, but
stimulation?
X-ray guidelines this time are very clear that clomiphene and letrozole are not to be added for any patient.
Okay, sir. So ESHRE 2025 says OCPS is okay if a 5 days washout period is given for synchronization. So, and also the dose of gonadotropins decreased in hyper and normal responders, that is around 100 to 150 respectively. Is that okay?
100 to 150, I understand.
I mean, like, they're saying that if we give a washout period, it's okay. That's what is the message from the ESHRE
Yeah, 5
2020.
to 7 days of washout period you have to give. Yeah. If you're giving
And
an HCG trigger, it doesn't really matter. This is all when you're using an agonist trigger that it matters.
okay. So, for adenomyosis, what is your protocol for embryo transfer, sir? You don't downregulate at all. So then, what do you
No,
do,
we
sir?
give only the one depot if we are doing a HRT FET. If we are doing a natural cycle FET, we don't need to downregulate. You obviously can't downregulate if you want to do a natural cycle. We are doing a lot of natural cycles now. I'm telling you, it's going to, all of you will realize it's one of the top 3 treatments for RIF, which we have neglected all this time. We
And
label
what
them
is
as RIF, and we have had so many pregnancies this year where previous FETs have failed, not only in other clinics, even in my clinic. And then the minute we do a natural cycle FET, she has straight beta HCG of 2000. So this is now a daily thing for us.
It is
So
so
seeing is
interesting to see
believing.
the
You know me, I never recommend anything very strongly until I am convinced that it works. So
yes.
modified natural and natural is something which is the future. We can't escape that.
And your slide, which is 30% increase, is something very
Yes, that is why I kept it at the end. Yeah.
yes, sir. And so, what is the luteal phase support that you give in natural and modified natural cycle FET, sir? And the luteal phase support which you give for natural cycle and modified natural cycle,
Just one MPP, and if she is a habitual aborter, then we add dydrogesterone.
that's all.
That's it. Yeah.
And do you do any monitoring, sir, during the modified natural or natural cycle, and how
Just a
frequent and what
TVS
is?
follicle monitoring. If I feel that I need to prepone her ovulation, then I'll just give 1 or 2 days of the antagonist HMG 150 to accelerate the follicular growth and trigger it. So that's about the maximum modification that we do. The natural proliferative phase we are yet to try. We've just done 2 or 3 patients, so don't have enough data on the success rates. But that's one thing which we definitely need to try.
But LH monitoring frequency.
No, 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 no. The
Okay.
minute it is 21, you ask the patient to keep a note when she feels her ovulation pain. 8 out of 10 will tell you that, okay, it happened at so and so time, yesterday night, today morning, whatever it is. And remember, if it has happened yesterday evening, you can still count today as day zero. So that much 24 hours of window is
Is
there.
there.
It's not that you have to be exactly on the dot timing the transfer.
You showed one very beautiful COS protocol where the triggering was delayed in PCO patients where like it was more than 18 millimeters.
Yeah,
So
that was
no
Itakura. He
concern
came
of
for ISAR.
premature LH surge, sir. Usually the E2 levels are quite high even on day 3 or day 4 in
No, no,
PCO
no. That
patients.
was the
There's
whole
no
thing that
concern
the
there.
paper proves now. No? A lot of these are our theoretical concerns. We've never tried it, did we? We never tried it and we assumed things. So this paper is showing us that it doesn't happen.
Okay. Someone has asked high E2 levels in FET cycle, maximum how much will you transfer? Do you monitor E2 levels? And also when we use vaginal estradiol, the serum levels are quite high, actually. Estradiol hemihydrate.
Yeah, yeah, yeah. No, so we don't monitor. No need to monitor.
Okay.
You can go maximum 12 milligrams of oral and you can give 4 milligrams of vaginal for just 2 to 3 days. I kept saying that case only for 2, 3 days.
So there is no high level of E2 where you will
No, no,
cancel the
no.
cycle in an
No,
FET.
no, no.
So how do you stimulate a resistant PCO patient, sir, where E2 was just 40 even after 4 to 6 days of stimulation?
You have to
Sometimes
step up your FSH. Na? Sometimes you have to go to 300. Sometimes you add 75 or 150 of LH, add HP HMG, switch completely to HMG. She will 100% respond. Of course, now once you go to 300, 375, she will have 40, 50, 60 follicles, which you expect. But there is no patient who never respond. They will always respond, but you have to not be scared and just keep stepping up the dose.
So in that novel protocol which you mentioned, where they were monitoring the FSH level and kept it between 5 to 10 milli international units. So in between there was coasting and other things. So it really doesn't affect the
It
cycle
doesn't
outcomes, is
affect,
it?
but it has to be a long agonist cycle. You can't do all this in an antagonist cycle.
Okay. So do you recommend that in long agonist cycle, when we are doing, we should also monitor FSH in our long protocols also?
No,
Is it
no,
going to
this is
help us?
only, this is just 2 case reports. Right now, we keep it at term simulation as one thing we can expect in 2026, maybe once we have the publication, that which patients it should be done for. So as of now, they have restricted it to for patients who just don't give you even one good quality embryo.
Sir, in your opinion, is there any particular gonadotrophin that can have, abnormal oocyte morphology? For example, someone has asked, does HMG should be avoided if there is large previous debris, etc., in the previous cycle?
No, 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 nothing like
There's
that.
nothing like
There is
that.
no such correlation.
But on the contrary, I wanted to ask your experience on PPOS protocol, where we do express some sticky oocytes, little
Yeah.
low-level blastulation
No,
on.
so right now I've kept it restricted. That's why I didn't talk too much about PPOS and I just showed you 1 or 2 slides. The euploidy concern for advanced maternal age and the higher pregnancy rates, which only one paper has shown as of now. So there's a word of caution there. It's not mandatory to switch to PPOS for all. That's why I said maybe end of the road for the antagonist if the query, question mark, we still don't know.
So you were mentioning that you don't monitor your cycle with LH or hormones. You directly
Correct.
do one ultrasound and then directly beta HCG. That's quite impressive. But then
Not one ultrasound, AMH test.
I
Ultrasound you
know,
have
I
to
know you
do
do
day
all that.
7, day 10,
But
day
then,
11 for triggering, and then
but then we are so, especially in the Poseidon group, the LH window and other things, we're so tuned to monitoring the LH levels and other things. So
how
with
does it
your,
help you? How does it help?
so frequently we encounter elevated progesterone levels after stimulation. So we cannot do fresh cycles. So how can we prevent it?
Elevated?
Progesterone levels,
Ah,
premature
that you
progesterone
can't. So
rise.
that's why your initial FSH dose has to be perfect. If you start with very high dose of FSH and you continue that high dose of FSH for the full stimulation, you will have PPR in high responders. So only women who have a lot of eggs will usually be prone to premature progesterone rise. But many eggs is anyway going to be a freeze all. So this problem you will not see in too many of your poor or normal responders. They will usually not have elevation of progesterone because they have fewer eggs. So fewer the follicles, less the tendency to PPR.
And also in Megaset HR trial, it was very good, no, sir? I mean, the HPHMG
Yeah,
showed slightly lesser.
exactly. They showed a half the miscarriage rate from 28% to 14%. Just Yeah, sorry, please.
Sorry, sir. Sir, you still do a lot of cleavage stage transfers, right, sir?
So that is one secret. So if you want to do a lot of natural cycles, you can't do blast for all. Okay, especially if your patients are say young, good prognosis is that you can do freezing on day 2, day 3. Like I still freeze embryos on day 2, so that I have a flexibility of 5 days.
Yes.
In a natural cycle, I can do day 3, I can do day 4, I can do day 5, I can do day 6 because my embryos can be grown cultured that much. So that is one more way of doing modified natural cycles without being worried of working on weekends and all that thing. But I know it's difficult for everyone to accept that. Most people, 90% want to make blastocysts for whatever reasons, thinking it gives better pregnancy rates. So to each their own. But finally, I
In fact,
think,
you have got a great experience in doing day 2 transfers.
yeah, in all my batches, in Agra, Cochin, Madurai, Road, Chennai, we never waited beyond day 2 because I couldn't stay that long to wait for blastocysts at each center.
Sir, you told early trigger in advanced maternal age. So, in Poseidon 3 and 4 groups, do you just use only HMG or use combination of FSH, I mean HMG and REC FSH?
Combination, all patients have combination. I don't have any patient who is only on FSH. Each and every patient will get LH from the beginning.
So
Whether
that
it be
solves all the
75
problems.
or 150, LH has to be given.
And in poor responders, what is your pre-adjuvant, sir? Usually testosterone 20
20
days.
days, coenzyme Q, resveratrol, leucine, glycine, vitamin D, melatonin for
And
60 days.
okay. And have you used GLP-1, sir, in your practice? Because there's recent data which I
Yeah,
read
yeah, yeah.
saying
But
that
I have not used,
pre-maturity
I have not started the stimulation while they are on it.
okay, sir.
That I am still, we need some more papers, no, adverse effects. Although theoretically, because it is a hormone which is already in the body, it should not cause any problem to the fetus. But why take a risk? So I just tell them you take this for 3 months. Even if usually they will lose 10 easily 10 to 12 kgs if they are 100 plus. So that is usually enough to improve the outcome.
Thank you so much, sir. There'll be so many questions for you. I know
I
it's a
know, I know.
busy evening. It cannot end here. You have concised one whole book, and I should humbly thank you for including embryo transfer protocol, though it is,
Yeah, because
I
otherwise
can,
it's incomplete,
without that is definitely incomplete. And thank you so much for sharing all the latest knowledge. I think we'll have to go and revise everything, all those papers, everything. It is indeed a great pleasure, and we humbly thank you for accepting this invitation to be part of our Scale Masterclass series. And
Thank you,
all
thank
the
you.
audience have benefited from this lecture. And thank you once again, sir.
Thank you, Vasundara. Thank you so much.
Thank you, sir.
Thank you, everyone who has joined us on your busy weekday. Thank you so much.
Thank you, sir.